Thank you very much. The next speaker is going to be talking to us about new classification and treatment outcome of hand vitiligo, a cluster analysis of 230 patients. So Dr. Hyun Jeong Ju, please. Thank you.
Thank you for the kind introduction. And I'm Hyun Jeong Ju from South Korea. And thank you for having me here and giving me the opportunity to present our study about classification of hand vitiligo. 3 months ago, a 60-year-old female patient visited my office with vitiligo on her hands. As acral lesions are very challenging, I was very pessimistic about the outcome. And surprisingly, after 2 months treatment of excimer laser and medical treatments, almost all of the lesions improved. This brought me to a question: are all these patients with hand vitiligo are going to show the same disease course and prognosis? Hand vitiligo is frequently encountered in our daily practice and is usually resistant to any kinds of treatments as well as surgical treatments. But it still has a significant negative impact on patients' quality of life as much as facial lesions do. So if we could better understand the hand vitiligo through classification, we will be able to provide a better management to the patients. So the next step will be how can we classify these patients. There's a lot of techniques to find out pattern among a large amount of data, which is called data mining. And the big difference between classification and clustering is that classification is dividing the data into pre-classified classes, while clustering is a method of partitioning data based on the similarities without any predefined knowledge. Hierarchical agglomerative clustering is the most commonly used simple clustering algorithm. We start by measuring the distance between each item and continue to compare with other pairs and find the closest pair in order to merge into the same group. We continue this until we end up finding the appropriate number of clusters. And all these entire sequence is shown in this structure called dendrogram. And in most cases, the scientist or researcher will determine the number of clusters at a scientifically most meaningful level. So we prospectively enrolled non-segmental vitiligo patients with lesions on the hands, and cluster analysis was performed based on topography of hands. And we divided hands into following 6 compartments. As you can see in the figure, the tip colored in orange was defined as the lesions from DIP joint to the very end of the fingertip. And finger colored in gray was covering the area from DIP joint to the MCP joint. And dorsum colored in blue was defined as the dorsal aspect of hands. And we assessed the level of involvement in each patient by scoring them the percentage of involvement against the entire area of the corresponding compartment. Let's see the results. A total of 230 patients were included, and interestingly, in 7.8% only the hands were involved. And the response after conventional combination therapy, excluding surgical treatments, over the course of 6 months, were able to assess in 102 patients. And you can see that 66% of the patients showed poor response. However, still 16% of the patients showed excellent response. Here is the dendrogram and heat map of our cluster analysis. And the row from top to bottom depicts the compartment, tip, finger, and dorsum, and each column corresponds to each patient. The darker the color, the larger area of involvement, and 3 total clusters were withdrawn. The patients in the first cluster showed large involvement around periungual area and lateral side of the fingers, and which eventually extended to the dorsal part, and we named this distal type. And patients in the second cluster showed predominant involvement of dorsal aspects, which we named proximal type. The patients in the last cluster showed scattered small lesions over the joint area and finger and dorsal. We called it intermediate type. And intermediate type was the most common type, followed by distal type, while proximal type accounted for only 6%. We compared several characteristics among these groups, and the onset age of proximal type was median 47 years old, which was significantly older than distal type. And disease duration of hand vitiligo was significantly the shortest in intermediate type and longest in distal type. Moving on to the treatment response, according to the subtype, patients in distal type were mostly poor responders, while about 40% of the patients in proximal type still showed excellent response. In terms of hand duration, patients with duration less than 1 year showed excellent response in 35%, while none of them with duration more than 5 years showed excellent response. According to the anatomic lesions, dorsum and finger showed better outcomes compared with joint areas and tip lesions. Logistic regression was further performed to figure out factors associated with treatment response, which revealed that disease duration was the single factor associated with the disease treatment outcome. So to recap, we observed 3 subtypes of hand vitiligo. First, distal type was involving the distal ends of the hands and lateral sides of the fingers, which showed early age of onset and very resistant to treatments. Proximal type showed involvement of proximal parts, especially the dorsum areas, and showed old age of onset with good treatment response. However, very small number of patients were included in this group, so we should interpret with caution. And last, intermediate type was patients with small scattered lesions over the joints and fingers, and we are not yet sure whether this is distinct separate type or whether it's early lesion, which will eventually evolve into either distal or proximal types. So to wrap up, disease duration and the anatomic lesions, whether it appears on the hair-bearing areas like dorsum or fingers, will be the most important factors associated with treatment outcome. Our study was limited by small sample size, and we did not consider palmar aspects, which should be analyzed in the future studies. And therefore, accurate classification and early intervention will be the most important part to enhance the treatment outcome of hand vitiligo. Thank you for listening.
Thank you very much. I was going to ask about the palms, but I see those were not included. Is there any question, one single question? Thank you, Khalid. We're going to have one question, and then the rest of the questions can be asked immediately after the meeting. Is that okay?
Thank you very much for
Sorry
this,
to disappoint the others. Please go ahead.
Thank you very much for this really nice study. And I think that what we are all thinking is that this part is probably more responsive. You demonstrated here. Did you have, because this is your validation sample, did you have another sample in which you tested the model? Another sample of patients?
No.
No, you just have this.
This sample, yeah.
Okay. I think it's worth to test in another sample of patients, the model, and you didn't calculate eventually positive predictive value and negative predictive value. The problem is that the sample is too small in the last, but really it's a very nice work.
Thank you.
Thank you, Khalid. Dr.
Excuse me,
Hyun Ju.
I just wanted to add something, please, because we had a similar study on about a cohort of 500 cases that we presented at the last virtual VIS, and we had the classification, but we added the entity of the knuckle involvement, because there are a good % of cases that have only the knuckles involved.
Mm-hmm.
But you are including the whole finger. Yeah, it's not only the distal and the finger. The knuckles are, there is similarity and the response to treatment between the knuckles and the periangles. So that's why, this might be missing in the classification. Thank you.
Thank you for the
Thank you. We are going to ask you to remain behind after the meeting because there's a lot of interest in your talk.